Hi, everybody. It's Mrs. Bartels. I'm going to finish up chapter 25 with you today. This will be your Friday daily assignment. It's the end of the slides, page 372 to 382 in the book. Okay, I'm going to go over to the slides. We'll go over to the slides in here. Here you go, guys. All right. Go down to... So we're going to start, we ended yesterday using the stethoscope and pulse sites, so we're going to start today on respirations. Okay, I'm going to switch over to slideshow for you guys. So respirations is the breathing that a person does per minute. Oh, shoot, that's not what I want to do. Hold on. So we're just quick. So when somebody breathes and we count their respirations, we're watching the chest rise and then fall. Each time the chest rises and then falls, that's one count. So it's a rise, fall, one count. Rise, fall, two counts. Okay, rise, fall, three. Rise, fall, four. So it's a set. You watch the chest rise, you watch the chest fall. It's a one count. Okay, so respiration means the breathing of air, taking air in, which is inhalation, and taking air out, which is exhaling. Okay, so when we take air in our lungs, when we take it in, it's inhalation. When we let the air out, it's exhalation. Again, each respiration as you count includes that inhale and exhale process, meaning the rise of the chest, the fall of the chest. So when we inhale, our chest kind of sinks in, and then when we exhale, it goes back out. Okay, so the rise and fall of the chest is what we're looking at. Respirations are normally very quiet. If you stop for a minute, and I'll do it in a minute, you'll notice if we're not talking and everybody's quiet, respirations are quiet. They shouldn't be making noise. They shouldn't be like wheezing, or you shouldn't like that, or a person wheezing. You shouldn't hear like coughing or rattling. It should be a quiet, smooth breath. They're effortless and they are regular, meaning they rise and fall at irregular rates. Okay, and they're not hyperventilating, and they're effortless. The person's not putting any work in. It naturally happens. If you stop for a minute, close your eyes, and just focus on your breathing. See how your chest rises and falls? It's quiet. You don't hear a lot of extra noise going on. It's peaceful. That's what breathing should be. The healthy adult usually has 12 to 20 respirations a minute. So a rise and a fall is one respiration. A rise and a fall is two respirations. So usually a person will do that 12 to 20 times in minutes. You want to make sure your person is not knowing that you're counting their respirations, because if they know that you're counting their breathing, they kind of have a habit of stopping breathing or holding their breath or talking to you. And then your count will be off. So what we usually do is we will take their temperature first. Then we'll take their wrist and hold it while we do their pulse. After 30 seconds counting the pulse, we continue to hold the wrist. So the patient thinks that we're counting their pulse still, but we're actually watching that chest rise and fall. So you kind of like psych your patient out. They think you're doing their pulse, but you're actually watching the chest rise and fall, and you're doing their respirations. Again, if you tell them that you're doing respirations, usually they get nervous and they'll either breathe faster or they might hold their breath. So it's better to act like you're just doing the pulse, but really you're checking those respirations. So you do your pulse for 30 seconds in the wrist, and then you go and watch the chest rise and fall for 30 seconds. You multiply that by 2, and you record it as how many it is respirations per minute, RPM. So if I get an 8, I count for 30 seconds, and I see the person rise and fall 8 times. 8 times 2 is 16. So respirations are 16 RPM, respirations per minute. Okay. I'm going to get rid of it so you guys can see better. If it's abnormal, meaning it's hard, the person's breathing really fast, they're hyperventilating, or it's a noisy respiration and it's hard to get it, count it for the entire minute. Okay. But if it's a normal, smooth rise and fall of the chest and you can easily count it, you just do it for 30 seconds and multiply by 2. If you're having a hard time, you do it for the whole minute and don't multiply by anything. Okay. We're going to talk a lot more about respirations and breathing in the next chapter, chapter 30, when we talk about oxygen use. Okay, here's blood pressure. Blood pressure is probably one of the hardest skills for you guys to do. Oh, I'm sorry, in your book on page 372 for respirations, know that inhalation and exhalation, know those two terms. Know the normal rate is 12 to 20 respirations per minute. That's in the second paragraph, page 372. And know that both sides of the chest should rise and fall equally. And don't tell the person about checking their respirations. That's the third paragraph. And remember, you count for 30 seconds and you multiply by 2. If it's abnormal, you count for the whole minute. That's the fourth paragraph, page 372. Okay. Now we're going on to blood pressure. So blood pressure is probably one of the hardest skills that you guys have to learn. It takes a lot of practice, and it takes everybody else being quiet and everybody trying to practice and listen. Usually we start blood pressures about this time of year, and we don't get everybody signed off. We usually have to wait. It takes a while to get everybody signed off. So usually we get kids signed off by like March. You're not going to be able to sign off if you don't practice. I'm going to tell you guys right now, you have to practice. And it's not a matter of grabbing the cuff and throwing on somebody's arm. Practice means we teach you step by step, because if you don't do it the correct way, you could hurt somebody's arm or hurt the artery. Okay, so we teach you slowly, so please be patient with us. So the blood pressure is the amount of force that's going through your artery wall by the blood. So when your heart is pumping and pushing the blood for that artery, how much force is going in there? It's the pressure that's going through. There's two measurements when we do blood pressure. The top number is called systole, and that's the point in time where your heart is not, where your heart is contracting, where your heart is squeezing. It's working. And the bottom number is called diastole. That's when the heart finally gets to rest. So systolic or systole goes on top, diastole goes on bottom. I always remember that because diastole kind of sounds like the word die, and when you die, you go in the ground. Okay, so I always remember diastole is the one that goes underneath. Okay, so systole is the top number, diastole is the bottom number. Systole is when our heart is working and contracting. Diastole is when the heart gets to rest a little. Okay, the systolic pressure is the pressure in the arteries when the heart contracts. So again, it's when the heart is working. The diastolic is when the heart finally gets a minute to rest. Because your heart basically has 4 rooms, and it pushes blood for the rooms. And as it pushes the blood, that's contracting. And then once all the blood moves to the next room of your heart, it can relax. And the heart fills up with blood again. And when it gets too full, it pushes again. Okay. And then the blood flows out and the heart is relaxing. And then when it fills up again, it's got to push it. So every time the heart gets filled with blood and it needs to move it, it's a contraction. And when the blood is moving out of that area, the heart gets to relax. So it's called relaxation. Okay. The normal range for blood pressure is a systolic, so the top number should be less than 130, and diastolic numbers should be less than 80. Okay, so if your person has a blood pressure that's less than 130 on top and less than 80 on the bottom, they are doing okay. Treatments, meaning if you get a blood pressure reading that's hyper or hypo, and we'll talk about that in a minute, too high or too low, treatment's needed. You need to get a hold of the nurse. Okay, so if the person is high or low, you need to contact the nurse. I'm going to explain that to you in the book. Okay, so on page 373, blood pressure highlights or underline what it is. The first sentence. It's the amount of force exerted against the walls of the artery by the blood. Okay, know what diastolic and systolic is, which one's at rest and which one's at working. I wrote in my book, so I always write in my book, I wrote systolic, SBP equals working, and diastolic, DBP equals resting. And then I also wrote in my book, S over D, because the systolic goes on top. Just like here you see, it says systolic on top, diastolic on bottom. So this blood pressure, if I would record it, be 130 with a line between it and then 80. So 130 over 80 mmHg. Okay. So you need to let us know, you need to let the nurse know if the blood pressure is too high or too low. If it's higher than normal, it's called hypertension. Again, high means hyper. Okay, so or hyper means high, tension is pressure. So if it's hyper, it's high blood pressure. If it's hypo, it means low. So it's low blood pressure. In your book, it gives you the parameters for that. So hypertension on page 373 is when the systolic blood pressure, that top number, is greater than 130, or if the diastolic blood pressure is greater than 80. So somebody can have a blood pressure that says 128 over 90, they have hypertension because that 90 is too high. Or they can have a blood pressure that's 160 over 100. They have hypertension because both numbers are too high. So if the number is above 130 or above 80, they're hypertension. Okay, and it doesn't have to be both numbers. It could be either or. So it could be like the bottom number is 100, but the top number is only 120. They're too high on the bottom, but they're still hypertensive. Okay, so hypotension is the opposite. With hypotension, your systolic blood pressure, so this top number, would be less than 90. And your diastolic blood pressure would be less than 60. So if somebody's blood pressure is 110 over 70, they're fine. But if somebody's blood pressure is 88 over 50, they're not good. That's hypo. Because again, if it's less than 90 on top, less than 60 on the bottom, it's hypotension. So if a person's blood pressure here, say, is 88 over 48, 88 is too low, it's less than 90, and 48 is too low because it's less than 60. Okay, it's in your book, you guys. I would write, this is what I wrote next to hypertension in my book. I put systolic blood pressure greater than 130, diastolic blood pressure greater than 80. And by hypotension, I put systolic blood pressure less than 90, diastolic blood pressure less than 60. Okay, so that's how I wrote it so I can remember it. And then the red box, it talks about if the patient sees the blood pressure reading or asks you what it is, what do you do? If it's an abnormal reading, you might want to just tell your patient, you know what, you could just say, I'm gonna have to contact the nurse about that. It was a little high, it was a little low, and I'm gonna have her recheck it. Don't be like, oh my God, your blood pressure is like 180 over 120. You're gonna stroke any minute. Don't do that. It's just gonna make them more nervous. Just tell them, you know what, well, I'm not allowed to tell you what your blood pressure is, but I'm gonna get the nurse. Or you might say, it was good, it was normal. But if it's abnormal, you don't want to tell them what the abnormal is because it might freak them out. Instead, just say, it was a little high or it was a little low. Are you feeling okay? I'm gonna call for the nurse. Okay? Don't tell them the numbers. All right. That's in the red box on page 373. Okay, we're moving on to the next slide. Pain. So we kind of skipped some pages in the book. And that's because when you guys are in class, we're going to teach you these pages, but we're going to go over the book anyways. Page 374 talks about the blood pressure equipment. Picture A is the cuff that we will be using to teach you. Picture B is an older aneroid manometer. So we do have some of the manometers in the lab. And picture C is a Dynomap or an electronic blood pressure. We do not do electronic blood pressures in school. We teach you guys the manual. So we're going to be using the blood pressure cuff, which you could see as a close-up in figure 2520. On page 374, the third bullet point, it says you wrap the blood pressure cuff around the upper arm. Tubing connects to the cuff. When inflated, the cuff causes pressure over the brachial artery. The blood pressure is measured as the cuff deflates. So the cuff goes above the artery, the brachial artery in the arm, on a bare arm. You pump it up, it squeezes the arm tight, and then as we let it go, the cuff starts to deflate and we get sounds. And we're going to show you that in a video. There are videos. I highly suggest you guys watch the videos in school with you about blood pressure and pulse. They're right underneath where your slides are and where your assignments are. Okay, on page 375 of your book, make sure you know that blue box 25.5. It says, do not take blood pressure on an arm with an IV, with a cast, on somebody who has a dialysis site in that arm, or somebody who has breast surgery on that side. So if I had a left breast surgery, you are not going to take blood pressure on my left arm. If I had a left broken arm and it was in a cast, you're not going to use that arm to take blood pressure. Or if they have injury on one side of their body, don't use the arm where the injury is. Let the person rest 10 to 20 minutes before you measure the blood pressure. It does make a difference. Make sure they are sitting or lying down, and their feet, if they're sitting, their feet are not crossed and they're sitting with their feet flat on the ground. Make sure you support the arm. The cuff goes on a bare arm. It should be tight. If it's too loose or too tight, if it's too loose or too tight on the arm, you don't have the right size, you're going to get an irregular reading. The first sound that you hear when we do blood pressure is the systolic sound, and you'll hear, it goes like this. You hear nothing. You pump it up, you start to open up your gauge, and you're like, Ms. Berthausen, you're not supposed to hear anything. So you'll hear nothing for a little bit, and all of a sudden you'll hear boom, 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 boom. So the first boom that you hear, the first boom, is your diastolic number. I'm sorry, your systolic number. And the last one is the diastolic. So again, watch what I'm going to say. We're looking at the gauge and we see nothing, and we hear nothing at 200. We hear nothing at 200. And then I start to open up the gauge and then going nothing, nothing, nothing. At 180, I hear boom, 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 boom. It's gone. That first number, when you first hear the boom, is your systolic number. When you don't hear anymore the boom, 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 and it goes soft, loud, soft, when you no longer hear anything, it goes silent again, that's your diastolic number. And there is a video, like I said, I need you guys to watch that video. We will do it in class too. Okay? And then you can see this picture on 375 about how the gauge is read. The long lines on the gauge are every 10. The little lines are every 2. So if you look between 90 and 100, you'll see it's 90 is one long line. The next line is 100s. But in between, there's little lines that are 2 points each, 92, 94, 96, 98, 100. You have to know how to read the gauge. So we're going to practice inflating the cuff and deflating the cuff, because you have to deflate it very slowly, and just looking at the gauge and learning how to read the gauge before we even put it on somebody's arm. Okay? Now we're going to go into pain. So pain is on page 378 of your book. There are different types of pain. Pain is when somebody, it's different to everybody. Some people might say they ache, they hurt, or they're sore. Some people might say that it's just uncomfortable. Okay, so everybody describes it differently. It means different. The meaning or the description of it is different per person. Some people have a very high tolerance of pain and they can tolerate pain. Some people, if they break a nail, are dying. It just depends on the person. Pain is a warning sign of our body. When our body's in pain, it's our body's way of saying something's wrong. I don't feel good. Fix me. So if somebody complains of pain, you need to take it seriously, even if you think they're not in pain, and report it to the nurse. It's very personal. You have to believe that if the person says they have pain, they have pain. Even if you think, no, they don't, they look fine, it doesn't matter. It's subjective, it's personal, and you have to believe them and report it to the nurse. We have different types of pain. We have acute, chronic, radiating, and phantom. So acute, just like an acute illness, it comes up kind of quickly on us, and then usually it will just go away. So it might be, maybe you were, I don't know, walking your dog and you tripped over a rock and you sprung your ankle, and your ankle starts throbbing and it swells up. Okay, you go home, you put the ankle up, you elevate it, you put some ice on it, you might wrap it in an ice wrap. In about a day or maybe 2 days, your ankle's back to normal. That was acute pain. Okay, it was uncomfortable, but you took yourself some Motrin, you elevated it, you iced it, you rested, it goes away. It doesn't last. It's acute. Okay, so it's usually with injury, trauma, you can see it, and sometimes with surgery. Like you have surgery, maybe because your tonsil's taken out. It's painful right after the surgery, but in 2 or 3 days, you're going to be fine. Okay, because that pain goes away. That's acute. Chronic is pain that does not go away. It stays a very, very long time. When somebody's diagnosed with chronic pain, they're basically going to have it for the rest of their life. You see that a lot with arthritis. You see that with spinal pain. You might see that in the elderly that have like bone disorders. Okay, rheumatoid arthritis is another one. So it's more of your chronic diseases that cause chronic pain. Radiating pain is pain that's felt at the site of tissue in the nearby areas. So a perfect example of radiating pain is you get pain in your lower back and then it shoots down your leg. It's called sciatica. Okay, so the pain starts in my lower back, but it goes all the way down my leg. It moves down my leg. It's like this sharp, like pain, like, ow, it hurts in my back, and then it shoots down my leg. So radiating pain is like shooting pain. Phantom pain is usually when somebody has an amputation. So maybe somebody has their leg removed. Maybe they were diabetic and they got a wound and they couldn't save the leg, so they had to do an amputation of the leg. With that, the body part is removed, like that leg would have been removed, but the person still will say, if we ask them, how are you doing? How's your pain? They'll say, oh, my pain's, in 8s. And we're like, where's the pain? She always asks, where did I have the pain? And they'll say, in my leg. And you're like, which leg? And she says her left leg, but she doesn't have a left leg anymore. So she's still having pain, even though the limb or the body part is not there. It's been amputated. And that's because when we remove body parts and we do amputation, we remove the piece, but the nerve endings take a while to die off. So the nerve endings are still sending messages back to the brain saying, hey, do something, my leg hurts. Okay, because the nerves haven't died off yet. So phantom pain can last up to 6 months. We got to wait for those nerves to die off and stop sending signals that the leg is hurting when the leg is no longer there. Okay, so it's kind of freaky, and believe it or not, we do give the person pain medicine when they complain of phantom pain. I know you're thinking that's crazy because they don't have a leg, so they're really not in pain. We still treat it like it's true pain, and we give them pain medicine. Okay. Signs and symptoms of pain. Let me see. She's got a slide for you guys. Yeah. So when somebody complains of pain, you need to let us know about that, and you also can give us some information. So you want to let your nurse know a couple things. If the person says, I just don't feel good, I have pain, you want to say, where are you hurting? Oh, I have a headache. Well, where does it hurt? Does it hurt on the left side, the right side? Does it hurt in the middle? Does it hurt at the top of your head? So you're asking the location or headache. Can you tell me when it started and how long you've had a headache? On a score of 0 to 10, this is the intensity. Can you tell me how bad it is? 0 means no pain. 10 is so bad you want to cut your head off. Okay. In pediatrics, we use the smiley face scale, which is on page 378. We also use that for the confused patient. If we ask somebody on a score of 0 to 10, 0 being no pain, 10 being the most, some people might not understand that. So we use the smiley faces instead. You want them to describe their pain. So you have a headache. It's on your left side. It started this morning. It's been here for 3 hours. And you're saying it's a 6 out of 10. Is it pounding? Is it dull? Is it sharp? So that's how you just ask them to describe it. And you could also ask them, is there anything that you think that caused it? Do you get headaches often? If you do, why do you get them? Is it because you don't have enough caffeine, or she don't sleep, or she has sinus problems? So you might want to ask them what, if it happens often, what do they think causes it? And you can also ask them what helps it, what affects it, what makes it better. And then you also check their vital signs and also see if they have any other signs or symptoms like nausea, dizziness. This is all on page 378 of your book. So don't just come to your nurse and say, oh, Mr. Anderson in 312 says that he has pain. You could ask these questions, because I'm going to say to you, what kind of pain does he have? Where does he have pain? Did you ask him how bad it was on a score of 0 to 10? Because if you find out that information from me and you report it back to me, I'm able to get his pain medicine quicker, because sometimes we have different types of pain medicine depending on how bad the pain is. Sometimes people have like Motrin or Tylenol ordered, but if it's worse pain, they can have like a Vicodin or a Norco. Or if it's really bad pain, they can have a morphine or a Dilaudid, something IV. So if you can kind of describe the pain and give me more than just he's in pain, I can try to get the pain under control more. Okay, and of course, we also assess the person for pain. All right, the next thing we're going to talk about, there's your pain scale, your smiley scale. The next thing that we will talk about is height and weight. So we measure a person's height and weight every time they are admitted to an agency. So when you come into the hospital and you're being admitted as a patient, they weigh you. You might not even know they're doing it because the beds have weight or scales built in them. So right when you walk in and you're put into your hospital bed, the hospital records the scale. If we set or has a scale that records your weight. Okay. If you're in a nursing home, they weigh you on a scale, either a standing scale or we have scales that wheelchairs can go on, but we weigh you. Okay. So anytime you're admitted to a hospital or a nursing home or even assisted living, you are weighed. Then, depending on what's going on with you, you might be weighed only once a month. You might be weighed weekly, or you might be weighed daily. Weekly weights are usually for people who are gaining a lot of weight or losing a lot of weight. Daily weights are usually for people who have heart problems and renal problems, kidney problems, and we have to be very careful about their weight and watch it every day because they have a habit of retaining, meaning keeping water in their body, so their weight can change from 2 to 3 pounds in a day. So we have to watch them very carefully because then we have to alter their medications and their diet. So those are your daily weights. We could do weights standing on a standing scale like this guy's doing. We could do it in a chair. We have the nursing homes, they look like plastic chairs and there's a scale attached to them. So the person sits in a chair. We could do it in a bed. The Hoyer lifts and the mechanical lifts that we use have scales built in. So if somebody's in a lift, we can measure what their weight is in the lift. And they also have one that's a flat one that's in the back of Miss Betty Jo's room. It's like a ramp that you roll the wheelchair up on and you measure the person while they're sitting in the wheelchair. You can measure their weight. Okay. There is math that involves height and weights. So on page 380, the blue box focus on math, you guys need to kind of look at that before you get into the lab next week so you understand what it means to zero scale out and how do you read a scale and how do you read the weight, the height part of it, the up and down part. It's not just the side to side. How do you take a weight? How do you take a height? We will show you, but it would be helpful if you guys also looked in the book and read page 380. Okay. When you weigh a person, the person only wears a gown or their pajamas. They do not wear shoes. So you're going to have to help them take their shoes off and help them step up onto the scale. Before you even do that, you ask them, I have to weigh you. Before I weigh you, can you try to use the bathroom? You want them to get rid of any extra fluid or even a bowel movement if they have it, because that will change their weights. So you want what we call dry weight. You want to do it usually in the morning, especially their daily weights, before they eat. So the best time to weigh somebody is first thing in the morning before they eat anything. If for some reason you weigh somebody and it's noon and it doesn't, every day that you weigh them from then out should be new. Okay, so that's why we try to always keep it consistent where we do everybody before breakfast. You use the same scale. So if I have to weigh Mr. Anderson every day because he has heart failure, I make sure that Mr. Anderson uses the same scale every day. Okay, or I use the same scale. Like I take care of patients in home care who are heart failure patients. So on the first day when I go out to their house to meet them, I bring them a scale. It's like, hello, welcome to home care. My name is Lori. I'm going to be your nurse. Do you have a scale? Most of them don't. And I'm like, it's very important with heart failure that you weigh yourself every day. Here's a scale. Happy home health day. Okay, so I put a scale in their bathroom. I show them how to use it. I explain to them they have to take their shoes off when they step on the scale, and they should only be in pajamas or a gown or their underwear because they're at home. Okay, so same thing with you guys, where you're going to tell the person, I want you to go to the bathroom, and then I'm going to help you take your shoes off. We're going to stand up on the scale, and you make sure they're only wearing a gown or pajamas. And then you have to learn how to balance the scale, which means moving the weights over to zero. And again, that is on page 380, explaining it all to you. Here is a picture of the height portion of the scale. So you will see, we don't look at the sides that are centimeters. We look at feet because we're in America and we measure in feet. So right now, this person, I see that he's 5 feet. And then we have to count where the red line is. So he's 5 feet. He's not 5. Wherever this line is here, this blue line is what he is. So I measured him. See how he's up there? I had him step off the scale, and now I'm looking right here, which when we blow it up, the picture is right there. I'm looking and seeing where does it end. So it ends 5 feet, not 1 inch, not 2 inch, not 3 inch, 4 inches, but he's 5'4", and there's one more hash mark, 0.25, 5'4" and a quarter. So 5 feet, 4 1/4 inches. So if we look at this closer, the feet are longer lines. Each inch is marked. So this is 5'1". Okay. This is 5'2". This is 5'3". So this guy here, he's 5'4". but he's got a hash mark that's marked there, and that's where it ends. So you got to give him credit for that. So the hash marks, if you look, are, here's 1 inch, that's a quarter, that's a half, that's 3/4, and now we're at 2 inches. So he is, if we look at this one, it'd be 5'1" if it was here, 5'1 1/4" if it was there, 5'1 1/2" if it was there, 5'1 3/4" if it was there. If he lands here, he's 5'2". So this guy is 5'4" and is 1.25". So he's 5'4 1/4". Okay. And you could write that 5 FT 4 1/4 IN. There's a couple different ways you can write heights. So when you're in class, we could show you those too. Okay. We're done. All right, guys, have a good day. I'm going to actually, hold on 1 second. Don't leave if you did. Hold on. And this, I'm going to go into Schoology and show you a couple things really quick. Hold on. Okay. Get out of here. Okay. Simon, the 25 and 30 folder in Schoology. Again, those are the PowerPoints right that I just did. Here's your daily assignments. But if you look, here's a video that you can watch on how to check a blood pressure and a pulse. So there's videos in here, and I'm going to click on them and show you. Share YouTube. Sorry, guys. He's coming up. There's one on how to do your pulse, which we learned yesterday. Here's one on respirations, how to do respirations, which we learned today. And there's a couple different ones on blood pressure. I really think you should read these and watch these, especially this one down here, because it's going to help you. This one is 2 students telling you how to do blood pressure. This one down here actually is practice on how to read the gauge. So this will help if you do this at home before you come in. Okay. So those are some videos for you guys. And also in Schoology, and again, the videos are right there. These are videos for the next chapter. Also in Schoology, we put a couple of different pictures for you guys to look at. If you go under Teacher Resources, you'll see there's one on labeling the blood pressure cuff. I'll show you really quick. It's the picture that's in your book. Okay, but we put it in here so you understand. This is the cuff. This is the gauge. That's the bulb. This is a valve that opens and closes it all and inflates and deflates it. And that's the tubing. Okay. And then if we go back, we have a picture of labeling a stethoscope. So again, because that's something that's going to be on your test, you need to know the parts of the stethoscope. So there it is. I have a worksheet for my kids. And I'm sure Miss Betty Jo and Miss Chrissy have it too. If not, you're more than welcome to come to my class and grab one if you want to practice labeling it, or draw on a stethoscope and label it. That's even more better for you. Okay. Then what else is in here? The stethoscope. These are assignments that will come up for you, not yet. There's a worksheet that we haven't given you guys yet. Matching. I'm trying to think what else might be in here. The pulse points are in here, a blood pressure gauge. So let me click on this one for you. It shows you the blood pressure up close. Okay. How this is 80. Next one's 90, 100. Every little hash mark is 2 points. So 80, 82, 84, 86, 88, 90. Okay. So I just wanted you guys to kind of see those. So take some time and kind of look in through Schoology, and you'll see we put a little bit of extra stuff in there. Here's one on the scale. The scale is tricky. Okay. So the bottom number is 100. So this person weighed 100, and the top number is 34. Okay. So 134 pounds, but then there's little hash marks. Again, it might fall in between. So it's 134.5. So when you get in class, we're going to show you how to do that. But you guys should have an idea on how to read the scales. They're in your book, and we're showing you pictures in Schoology. Okay. All right. I think that's it. There's some stuff that you won't see on your screens, and that's just because it's work that we're going to be doing in class or that we'll be handing out to you a little bit later on. Okay, you do have a homework assignments. So if it goes back into 25 and 30. And it says right here, in case you didn't see it yesterday, when you click on yesterday's assignment, it says, your temperature, pulse, and respiration packet is under the module 3 skills. That is your homework assignment. So if you have not been in class since yesterday or today, and you're not coming until next week, you should already be working on this packet. It's in the module 3 skills folder. Get in there and start working on it. Otherwise, if you were in class yesterday or today, you probably got a copy of it. Okay? All right. That's it, guys.